So, welcome to our second episode of Carilion Clinic's Antimicrobial Stewardship Podcast. We plan to use this series to discuss topical infectious diseases issues. The series is being made by medical professionals for medical professionals. I am this episode's host, Nick Stornelli, a board-certified infectious diseases pharmacist here at Carilion Clinic. I'm here today with Dr. Jason Faulhaber and Dr. Nathan Everson, and I'll let them introduce themselves.
Hi, I'm Jason Faulhaber. I'm one of the infectious disease specialists here. I've been at Carilion Clinic for over 11 years now.
I'm Nathan Everson. I'm one of the infectious disease pharmacists, like Nick. I've been here at Carilion for right about 11 years as well.
Well, great to have both of you on today's podcast. We're going to focus our conversation today around sexually transmitted infections. So Dr. Faulhaber has extensive experience in managing STIs, and Dr. Everson has only recently started a sexual health clinic in the last couple of years. And we have a series of questions that our guests will use to share insights from their direct patient care experiences, as well as provide us with some updates to current treatment paradigms. So I think the best place to really start this podcast often is a very difficult area for a lot of patients and providers. And that is the conduction of a thorough sexual history. Sexual histories are not always the most comfortable for the patients and the providers. Could you both offer some insights on what really makes a good sexual history and tips for our providers to help them be more comfortable during taking or obtaining these really important medical histories?
Yeah, so I'll go first. The biggest thing is to acknowledge that it is really a sensitive topic, potentially even for everybody involved, you as the provider as well as the patient. And you really want to establish some kind of safe environment, someplace where there's a lot of trust, so that way they can share very specific, intimate details, make absolutely no assumptions, try to be as non-judgmental as possible. So, for example, when asking about sexual partners, I ask, are you sexually active with men, women, or both? I also personally incorporate a lot of humor into it to try to help kind of diffuse the tension that can be surrounding this and to make a little bit of lightheartedness to it. So when asking about, total number of sexual partners lifetime, and people often just kind of look up to the sky and start to count. And I said, well, if it's greater than 1,000 works for me. And then immediately it's like, oh God, no, not that many. So it helps kind of break that up a little bit. And if there is more than one person in the room, so a partner or anyone else that's there, caregiver, et cetera, it's important to really get the patient alone. And so to ask that other individual to step out, because you're going to be doing a private exam or something, in order to make it, a different, more select, private environment for the patient, and so that they can share things that they may not necessarily want to share in front of the other person.
I think that's really some great insight from your perspective, Dr. Faulhaber. Curious to hear a little bit about Nathan's angle on that as well. Often, sometimes in our ID clinic, we may need to step into the room to get medication history and may go into a little bit of detail about sexual health history as well from the pharmacist perspective. So, Nathan, any additional sort of commentary about your role in that?
Yeah, with our newly developed sexual health clinic where we offer pre-exposure prophylaxis and STI testing, I definitely have not taken a ton of sexual histories prior to that point. So been a little bit of a learning curve. I think that everything that Dr. Faulhaber mentioned is really spot on. I think that initial conversation up front and establishing a bit of a relationship before launching into a sexual history is really important. I think also making sure the patient feels like they have agency in the whole thing, to know that at any point in time, they don't have to answer a question, they can back away, and knowing that they have control over the situation, they're not, feeling powerless. There's been some great moves within the medical school to really move towards having sexual trauma as part of some of these sexual histories. So making sure that you're aware that there's a potential for sexual trauma in the past for some of your patients. I've actually run into it far more often than I was initially expecting. And so making sure that you're creating a space where they're comfortable talking and able to ask about a history of sexual trauma may definitely help sexual histories go a little smoother. Definitely not making assumptions. I've had some very fascinating conversations that I would never have expected. So being really open-minded when you're approaching the sexual history, and at the end of the day, often we are worried about making the patient uncomfortable, which makes us uncomfortable. But the main thing that's going to make a patient uncomfortable, at least so far in my experience, is if they can tell that we aren't. So being as safe and calm and open as possible is gonna put the patient at ease. So I'd say those are kind of my observations for kind of starting to do this over the last couple of years. It's been a pretty interesting experience. I have the benefit of having patients who are coming in knowing it's a sexual health visit, so probably more likely to have that conversation as opposed to a patient who you're seeing for something else, but you need to have a sexual history, and maybe the patient isn't prepared for that. So that's another layer that making sure you have that pre-conversation with a patient to kind of set up the expectations of how this conversation is going to go and what their agency is.
Yeah, Nathan, I think you bring up a really great point about, where we're seeing patients. We may be a little bit biased in terms of seeing patients that are maybe more prone to discussing than in, the primary care setting. So Dr. Faulhaber, do you have any comments for, our patients that are being seen in family medicine clinic, internal medicine clinics from just overall health maintenance? Do you see sexual history as something that should be obtained at every single visit? That primary initial consult or intake into the primary care setting, is there a way that physicians should either be asking, separate questions on those, new patient visits, or how do you think we should keep the conversation going throughout multiple times per year when we're seeing those patients to make sure we're getting the best possible sexual history?
Yeah, so sexual health is part of your overall health. So it is important to have an idea of what people are at risk for. And so oftentimes what I would say is, I don't care what you're doing or who you're doing it with. I just need to know what you're at risk for. So in the initial, like when you're doing an initial evaluation or a complete physical, that is an important part, and that should be part of everyone's routine set of questions that are asked. And then for each subsequent visits, obviously if someone's coming in for a sprained ankle, may not necessarily be important to ask that. But if it's a routine follow-up for high blood pressure, for example, or for diabetes, just simply slipping in the question any changes in your sexual history, any new partners, or anything that you're worried about that may be of concern to you.
So that's really some great insight from our team here on this podcast. And I do appreciate you sharing all of your insights and thoughts on obtaining that history. I do want to shift a little bit over to, starting to engage in some conversation about some of our most common STIs. We'll start with, the big elephant in the room recently. We've seen a lot of cases on the rise for syphilis. It's one of our most common STIs. And what are your thoughts about areas of syphilis management to start with our kind of first pathogen that we are going to talk about today? What do you think are some of the most difficult pieces of managing syphilis in our patients?
Probably having the medicine available, um, given recently the shortage with Bicillin. But syphilis is really fascinating in the sense that it's been around for over 500 years and it's never developed any resistance to penicillin. The other thing about syphilis is that not only can it just present in any way, shape, or form, hitting every single system of the body, but you don't develop true protective immunity to it. So you can get syphilis multiple times in your lifetime, even multiple times within a year. Um, but it is curable. With the appropriate therapy, it's quite curable. When there's no symptoms present, or nothing that's very obvious, then the problem is that it can spread basically like wildfire within sexual networks. And so it's one of those kind of like complicated spider webs, and that once it gets in, it can just travel all throughout. And then you can easily end up with an epidemic.
Yeah, and you mentioned, first and foremost, right now we're dealing with a time of shortage of the key drug for all varying stages of syphilis, and so I do want to get Nathan's perspective on a little bit of not just the medication challenge right now, but from a pharmacist angle, what do you foresee are some of the areas of syphilis management that can be quite difficult?
Yeah, so I think that one of the interesting things from a pharmacy standpoint is, or a treatment standpoint, is Dr. Faulhaber's observation that there hasn't been resistance ever. But also, like, it's been around for a really long time, and we have two treatments. We've got penicillin and we've got doxycycline, and that's really the majority of the medications that have been studied for it, which is kind of unusual for an infectious disease to have so little or evidence-based options. It currently, and this is probably the third time this has happened, there's been national shortage of penicillin, benzathine or bicillin LA, and which is the option for IM injection. We also have penicillin procaine or bicillin CR, which is not appropriate for syphilis management. And so, kind of, a lot of health systems are keeping that bicillin LA specifically for these patients. Doxycycline is an option for syphilis patients, but generally we're all thinking for our early stages only. So, primary syphilis, secondary syphilis, maybe early latent, but definitely nothing other than that we could consider doxycycline for. Generally, penicillin being our preferred option, even in cases of considering desensitization for penicillin for really complicated cases when we're talking about tertiary syphilis or things like that. So I think that that's a really interesting component of for a disease that's been around since the dawn of humanity practically is has so little research into other treatment options. Um, I think from a treatment standpoint, and as a pharmacist looking at syphilis, I find the diagnostic piece of syphilis to be very intimidating sometimes, because syphilis presents so many different ways. Often people haven't had a test in a long time, and so we kind of assume that. We have to sometimes assume that they've had it for a long time if we don't have a history of a chancre or when they actually started. So it's a place where I often rely heavily on my physician colleagues to discuss the diagnostic elements and the staging of syphilis, which I feel like is not terribly easy. And I think sometimes even my physician colleagues err on the side of caution because we don't really know where they're at in terms of staging. So I think the treatment, albeit relatively straightforward, because there's not a whole lot of options as long as you have them not on national back order, of course. But I definitely feel like the diagnostic piece is by far the more complicated aspect of syphilis, at least for me.
Yeah, and I absolutely for me as well. And I do want to kind of turn it over to Dr. Faulhaber a little bit to kind of get the sense of, what should we be doing from a testing perspective in, primary care outpatient clinics? And what are you doing for syphilis testing? When do we do it? How often? And then, follow-up testing interpretation. Often, sometimes we see patients that have had multiple non-treponemal testing done, and how do we interpret that in the context of the full patient?
Yeah, so the world of testing for syphilis is kind of broad. What we do here locally, notably also just kind of on the eastern seaboard, is that we do the screening test with an RPR, so a non-treponemal test. And then if that is positive, it should reflex to a titer, which is going to be a number that's going to help us with managing and monitoring the response to treatment. The other thing that it will do once you an RPR is positive, it will reflex to the treponemal test, which what we use here is the FTA ABS. And that being an immunologic test or antibody based test should stay positive for essentially for life. So once that is positive, that doesn't really need to be checked again. So really, you're just checking on the RPR, the titers, and make sure that it falls with a factor of at least fourfold after treatment in order to determine that it's truly successful therapy. That being said, as I said before, that this can run rampant and you can get it multiple times. There's always the chance for getting reinfected, and then having to continue to use that RPR monitoring to determine if someone has been reinfected, re-exposed, or potentially that the treatment didn't actually work. So you do monitor those usually after a positive, somewhere in like kind of the 3, 6, 9, 12 month range ish. For those who have a negative test, you would continue to test them or screen them based on their risk. So when we're talking about PrEP, which we'll talk about later, I'm sure that we will monitor that basically with every visit as part of a screening for sexually transmitted infections.
Yeah, that's really great to hear kind of those insights for follow up testing, to where to test, how to test, and how to interpret them. This we're talking specifically about syphilis, which is just one of many STIs in the armamentarium that we may see of our patients come in with. I think with syphilis, and then kind of spilling into some of our other STIs that we see, when that initial visit for a patient that has, after a proper sexual history, what's your approach to selection of appropriate tests? Are we sending everything? Is there screening that is maybe based on that specific sexual health practice? And I think you may be kind of seeing that I'm hinting at a little bit, talking into gonorrhea and chlamydia next. That's our next topic to go through. We see maybe more providers that are comfortable with managing gonorrhea and chlamydia, but you often get referred a lot of patients in our ID clinic that are coming in that require management of these paired STI combos. So I kind of want to spin into the gonorrhea discussion a little bit. Where do you see opportunities for diagnosis here? What's your approach to taking in that patient and screening?
Test everything and test often is probably the easiest way of saying this. The chlamydia and gonorrhea can really basically be in any kind of mucosal surface. So not just the urethral tract, but also rectal mucosa, vaginal mucosa, as well as oropharyngeal. So if any of those areas of the body are being utilized in any way, shape, or form with another partner, then those areas should be tested. The testing has gotten easier, especially with newer molecular diagnostics. We don't necessarily have to swab everywhere, notably the urethra, that we can do a urine sample for that. But the other areas, which harder to do, obviously, but would be rectal and or pharyngeal, as well as cervical, that you do actually need to swab in those settings. The other thing is that with regards to chlamydia and gonorrhea, more often than not, people are asymptomatic with it. So even though they have no complaints, again, as long as they're using any of those areas of their body, then those need to be screened or tested.
From a management standpoint, for gonorrhea and chlamydia, there have been some new changes, or there's some preference changes recently where doxycycline has been preferred over azithromycin per CDC recommendations for management. Um, there's definitely, I would say, there's not a consensus in the ID world about which is technically better. Data does show that doxycycline is a little bit better cure rate, particularly when we're talking about anal infections or pharyngeal infections. But there also is the component of a single dose of azithromycin is there's better chance of compliance. You're able to treat somebody potentially all in one visit if you're giving them the IM ceftriaxone plus the azithromycin, and that all that treatment's done. So from a public health standpoint, there's still a really good rationale for why azithro might be preferred in certain patients. But from a clinical cure standpoint, doxycycline does kind of edge out over azithromycin in that regard. So we are seeing providers kind of using both approaches. There have been some changes with the dosing for ceftriaxone as well, which is still relatively new. Everyone's used to that 250 milligram dose of ceftriaxone, but now the base dose is 500 for everyone, and this is due to rising resistance rates with gonorrhea across the globe, actually. And then, and for patients who are over 150 kilos, we're actually using 1 gram of ceftriaxone intramuscularly for those patients. So there's definitely been some changes because I feel like the treatment for gonorrhea and chlamydia has kind of been the same for a really long time. And so there have been some recent updates that everyone may not necessarily always be aware of. I think the part that sometimes I forget about would be some of the test of cure standpoint. So from your point of view, Jason, like generally we're thinking like urinary or urethral doesn't really require a test of cure, but would you be looking at test of cure for both pharyngeal and anal infections for gonorrhea and chlamydia?
Well, it would depend on what they received for treatment more than anything. And again, also what they do from a risk behavior. So if they do have multiple partners within a year, for example, then I would want to kind of make sure that we did treat it completely. Um, in those individuals, for example, for PrEP, or that we're doing routine monitoring every 3 months and doing screening that way, I don't really consider it as a true, test of cure in that sense, because it really is just kind of routine screening. And really, what you're trying to do is just catch for reinfection, because if their partners were not treated, then there's always the chance of getting reinfected. So, you know, I don't necessarily consider things technically as a test of cure. I just consider it more of a continued monitoring and screening for any active disease, and in this case, reinfection.
Yeah. And one of the themes that keeps getting kind of brought into this conversation is about the partner, the patient that we're seeing in clinic. They may have a patient that may not be part of our current, care continuum in the outpatient setting. So can we talk a little bit about, partner therapy? How do we assess and address, patient that may come in and have, recurrent STIs? Is there any offerings that we have either locally or within our state for partner therapy? How do we do that?
Yeah, so expedited partner therapy is really fascinating. It changes from state to state. So there's some states that expedited partner therapy is not allowed at all. And so kind of the core definition of expedited partner therapy is going to be you have your index patient there, that's your patient, and then they have exposure or sexual partners or wherever that you don't have a patient provider relationship with, but are able to still write a prescription for. And so that, every state has different legalities in terms of what constitutes a patient provider relationship. Well, Virginia does allow for expedited partner therapy. So that means you can write a prescription. It still has to have all the components of a prescription that legally would need to be there, except it does not require a patient name. Generally, people will put expedited partner therapy on the script. Now, there's an opportunity for confusion for both the pharmacies who maybe aren't used to getting these scripts as well as the provider. We at least for Carilion providers, we are in the process of developing a smart set that will be available in the ambulatory setting where you can actually print out these prescriptions on, they'll come to the prescription printer and you can select how many you want for each specific treatment. We're creating it for trichomonas, uh, gonorrhea, chlamydia, as well as syphilis, and so you'll be able to kind of easily access those from a smart set to print those off for a patient to take with them to give to their partners, who then can take it to a pharmacy to get it filled. So there really isn't a way to e-prescribe any of that sort of stuff. It does have to be done usually physically, because most e-prescribing requires it to be attached to a patient, which there really isn't a way to do that. But that is something that Virginia allows. It's up to the individual provider if that's something that they're comfortable with. And not every patient, EPT isn't necessarily for every patient and every patient's contacts. Ideally, in a perfect world, those contacts would also come in and get evaluated, particularly if their partner is at high risk for other STIs and should be tested for the whole kind of gamut. That may be better for them to come in, but it does offer a way for us to have an impact on some of that like STI burden in the community to help get folks some treatment easier than if they have some barriers to getting access to healthcare. Generally, patients can still use their insurance to get the medication filled, though a lot of these medications are relatively inexpensive. They can still provide their name and everything when they go to the pharmacy with the prescription to get all that updated. So it's it's pretty interesting. It's relatively new that it's allowed in Virginia, so I think a lot of health systems are still kind of evaluating the right way to approach it. But we hope within the next 6 months or so to have the process up and running for Carilion providers to be able to do this pretty easily right from the electronic medical record. Jason, have you ever done EPT, at least in your previous, either at Carilion or in your previous locations? And like, is there patients you wouldn't, or like, who would you not do EPT for? When would you be like concerned about it?
Yes, so I've done EPT both prior to Carilion and here at Carilion. Well, I would say that one of your support systems that you have is VDH. So the Virginia Department of Health that has an entire basically division, partner services that allow for partner notification and can help with navigating EPT as well. So you, as the provider, don't necessarily have to do the EPT with your patient. Obviously, your patient has to provide or at least has to be willing to contact their sexual contacts in order to get treated. But it tends to be a little bit easier when they're your patient because then you've already established a relationship with them, a rapport. Usually there's trust as opposed to, someone from the outside. And some patients may consider VDH, kind of being like, ooh, the government, and, may not be comfortable with them or even actually disclosing all of their partners' contact information in order to do contact tracing and then getting therapy that way. Um, I I actually don't know any specific time when I wouldn't do EPT or wouldn't favor EPT. It really, in order to help control spread, you need to treat everybody who has it, or in this case, potentially has it. And if you had a patient who comes in with chlamydia, test positive, and then says, "Well, I've had 6 partners in the last month," then that's important to try to be able to help control the spread there. If they say they've only had 1 partner in the past month, still that's important to help prevent the spread. So I strongly believe in EPT.
Yeah, it's really exciting to hear that there's going to be some more developed out smart sets for providers to be able to order EPT and kind of have that tool in their hands, as opposed to like, taking a little bit of the manual, writing out of orders in that sense. And so I appreciate both of you for kind of going into depth as to EPT, gonorrhea, chlamydia screening, as well as some of our treatment of STIs before. And so Dr. Faulhaber, you brought up a really great kind of concept of, EPT as a way to prevent spread. And so that's a constant theme, or a theme that coexists with STI discussion, sexual health discussion. And so kind of in our area, the next topic, kind of pivoting a little bit, we're focusing a little bit on treatment, but let's talk a little bit about prevention. So in Southwest Virginia, we do have a substantial HIV population, and potentially many people in the area that could benefit from pre-exposure prophylaxis or PrEP. So, PrEP, as we're familiar, is just taking antiretroviral medication to prevent HIV transmission. And the data is quite impressive that it works very well at this. However, we do see from time to time locally and also in the literature that there is often some hesitancy with from non-infectious diseases providers to be prescribing this for patients, and particularly the primary care setting. So, Dr. Faulhaber, could you talk a little bit about your perceptions on why this may be, and why it makes sense to be a part of primary care?
Yeah, so it goes back to, when we were talking about taking a sexual history and developing a good rapport with your patients, but also recognizing that it's kind of difficult to talk about sex. And for some people, it could be a personal bias. Down here, we are still in the South. There is definitely stigma around HIV as well as around sexual activities. Um, so that could be playing a role into why certain providers, non-ID providers, may be hesitant with doing this because it may not be on their radar. They just don't feel comfortable with it. They've never done it before, and it's something new, and they feel like it's outside of their field of expertise. But it actually sits really nicely nested in primary care because it is still like sexual health is still part of your primary care health of everyone. So it can be easily be done. There are lots of resources out there, including even within Carilion, that we have for providers who are interested in doing this. There are training videos, modules, and we also have specific documents that can make it easy. And obviously, we're always around to help, either to see the patients ourselves from a referral perspective or to help providers navigate the world of prescribing for PrEP and how to manage PrEP.
Yeah, I definitely see that as, back to that concept of discomfort. It's a really difficult topic, but it does, completely agree. It fits very nicely in overall primary care management. And we know we want to be able to uplift our primary care docs and teams to be able to see that kind of align with other disease states that they're managing. And so, Nathan, I do want to get your perception of this as well as your perspective on ways that within Carilion that what are some resources that we have internally or externally that could really elevate the primary care practice and assist with kind of that piece that patients may want to have consolidated care only at one site and not necessarily have to come to a separate clinic. So what are ways in your eyes, Nathan, about how we can continue that conversation into the primary care space about PrEP?
Yeah, that's a great question, Nick. The A lot of our patients in our pharmacist-run sexual health clinic are actually usually referred to us from the drop-in center, and they don't have a PCP. So it's a great opportunity for us to get people on PrEP as they're maybe establishing care. But we do have a decent amount of folks who have been referred to us from primary care, and in all those situations, we usually reach out to the primary care doc and offer training if they're interested. So we do for Carilion providers, we do offer free training, usually only like a 30 to 45 minute, virtual, or we could also be in person if preferred, to go over generally the approach to doing pre-exposure prophylaxis. I think in my experience so far talking to providers in this space, I think they're often very intimidated by the actual antiretrovirals themselves, is that they've never written for an antiretroviral. They're used to ID owning all of it, and they're just not that familiar with it and are worried about doing harm by writing for something that they're not that familiar with. And so they're also worried about the patient being able to obtain the medication because they rightfully assume that getting antiretrovirals can be a little bit difficult. The nice part about some recent changes is that every insurance other than Medicare, which Medicare still usually does cover it, but all other insurances are mandated to cover PrEP. And they're supposed to cover it with zero cost sharing. So it should be no copay. That doesn't always happen because insurances don't always follow the rules, but they're generally writing for the generic of Truvada, tenofovir, emtricitabine, is going to be covered by almost every insurance, usually without a PA. And that's like a relatively recent development within the past couple of years. So I think from an affordability standpoint and an access standpoint, insurances are generally covering PrEP relatively well. The newer option for PrEP, Descovy, or tenofovir alafenamide, that piece is still not covered super well by insurances, and we can sometimes try to work with them because that's the option we're going to use in patients who don't have that excellent kidney function, where we'd be worried about that with Truvada. Um, so there is a little bit that can be a little difficult in selecting those two agents, but if you've got a patient who is an excellent candidate for Truvada, it's really easy to get it. Monitoring is usually an every 3 month sort of situation. We have a toolkit that we developed at Carilion, for providers to do this. It walks through, has treatment guidelines, it has monographs on the drugs to kind of help get you up to speed if you're not as familiar with it. It has a really nice infographic of how to do all the monitoring, what tests we order, and that is all available on both our inside Carilion hub. It's also available for all providers, even outside of Carilion, on our internet site for antimicrobial stewardship. So we have that toolkit there. We have STI guidance. And the toolkit does even have some tips on how to get things covered if you have some issues with that. But again, we're not seeing that being a major issue right now. The bigger component is making sure that you're doing the regular monitoring and the patient's connected to care and that sort of thing. So not only do we have actual documents, but we do offer straight up in-person training for anyone who wants it. So I think we've got some really good tools here at Carilion to help people write for PrEP. And then if there's a situation where a provider still really isn't comfortable with it, we have a clinic within our ID clinic that can see patients. We see patients a couple of days a week, and generally we have availability within the next week for the pharmacist-run clinic. It'll be a little bit longer if a patient would prefer to see a physician, maybe a month or so to get in with somebody, but we can see people pretty quickly if they really want to get on PrEP. Additionally, there's some other great resources for PrEP in our area. VDH offers PrEP. And so for patients who don't have insurance, that's a really excellent place to send them because they have a sliding scale payment wise. VDH is also very comfortable working with undocumented patients, which has come up before, is that patients who are undocumented may be really concerned about going to some place like VDH because, as Dr. Faulhaber mentioned, kind of has the government energy and are worried about that. But VDH will happily accepts undocumented patients and is okay with that relationship. So that is another option that's out there for patients who are kind of uninsured. Because really the biggest struggle with PrEP from an affordability standpoint is usually going to be the testing. So like HIV tests, hepatitis B, hepatitis C, those are not cheap tests. And so if you don't have insurance to pay for those testing, that can be relatively expensive. And also Planned Parenthood here offers PrEP as well. So several different options for providers, and we're always happy to take questions. If you're in a Carilion provider, e-consulting the infectious disease pharmacy, we can review a specific PrEP case, give some guidance about it. So we have lots of options for you to reach out and engage about those patients.
Yeah, thank you, Nathan. That's a really awesome plug for some of our resources available on our antimicrobial stewardship hub. So please check that out. We'll also be providing, some links to these exact documents and clinical guidance in our show notes for this podcast. From, kind of on the same topic, just from a broad stroke, what are some, tips and tricks for primary care providers to just get the conversation going for PrEP? How to introduce the idea? Who should be ideally screened? I know a lot of our toolkits kind of goes into that, or the documents that we have go into like screening. But Dr. Faulhaber, from your perspective, how would you vision the best approach to entertaining you have a patient that you think would benefit from PrEP? How do you start that conversation, or how do you identify patients that could benefit from PrEP?
Well, usually it's just ask. That's probably the easiest thing to do. Sometimes, it may slap you in the face where you have a patient who's coming in for their fourth case of syphilis that they're being treated in within the past year or two, and say, well, it seems like you may be at increased risk of other STIs, including HIV. Have you thought about the possibility of doing PrEP? Sometimes we even have patients who have had to do HIV post-exposure prophylaxis, so PEP, and then saying like, well, clearly you have risk because you're coming in after having an exposure. So have you thought about doing something pre-exposure, and then basically initiating the conversation that way. Some patients actually will bring it right to you and say, "Hey, I'm interested in PrEP." So that's always good, especially if a patient is being their own advocate. But like I said, sexual health is part of the overall care of people. So should always be considering, or at least asking questions about what could your risk be and how can I better help you with that.
Yeah, those are both excellent time points, I think, to think about PrEP. And I think the literature kind of supports those time points as well, that positive STIs is a great like point to bring up PrEP. And then post-exposure, another great place to bring up. I have at least 3 patients in my clinic who are on PrEP following post-exposure, and kind of were unaware of their risk and unaware of even the opportunity for PrEP. And I think that's another thing that we struggle with a bit in our area, is that in some of the more metropolitan areas, the gay community has definitely really picked up PrEP, and it's become very like a kind of part of the culture. But that isn't necessarily always the case with some of the more rural areas. Whereas I feel like even in the LGBT community, where PrEP generally is pretty well known and established, I don't really think that's even the case here. So there's still uh, a lot of people who could benefit from PrEP who don't know about it. And there's even outside of MSM risk factors, there's still a lot of like heterosexual risk factors that patients could qualify for PrEP, and in terms of their sexual habits and kind of what their situation is. Often we have sex workers who don't realize that they could benefit from PrEP, and aren't always necessarily stating that that's something that they're doing with their providers, that for us to even think about offering that as an opportunity. So there's some really great communities that could benefit from PrEP, and I think that we as healthcare professionals can help kind of look for those opportunities and kind of ask those questions.
Yeah, so some really great discussion from our panel of podcast experts today. I do really want to thank both of you for your time and sharing some of your in-person experience with all things sexual health, STI, HIV prevention. Dr. Faulhaber and Dr. Nathan Everson, thank you so much. I hope these thoughts resonate with a lot of our healthcare providers and professionals on the inpatient and outpatient sphere. And for everyone that's listening, thank you so much for trying out our podcast series and listening in for both this one. We've done a previous podcast on asymptomatic bacteriuria in the past, so feel free to check out that other episode. All of these resources that we've discussed, particularly from our PrEP resources and prior guidance, will be attached as links in the show notes. You could visit our ambulatory antimicrobial stewardship website for more treatment guidelines and resources at your fingertips. Please do not hesitate to reach out to our antimicrobial stewardship team for any patient care questions that you have. There's contact information that's provided on our stewardship hub. With that wraps our second episode. Do want to thank Dr. Faulhaber and Dr. Everson for their time today.
Thanks, Nick, Nathan. This has been wonderful.
Yeah, thanks, Dick, and thanks, Jason. This has been great.